Good afternoon, everyone. Thank you for joining ahead of time. Appreciate that as everyone gets connected to audio. We'll run our disclosure information in the background as you are settling into the noon hour and hopefully getting something to eat, taking a break. I suspect for some of you it's already been a long morning. We'll give it a few minutes and get started shortly after noon Alaska time.
Did you want us to put our information in the chat?
You have read my mind. That would be fantastic, if you would. Yeah, if you want to throw your location and your area of specialty in the chat, as well as anybody else who might be with you, if there's more than one of you at your site. Amber, thank you for modeling that so nicely. Yeah, we do. We have multiple time zones and locations accounted for here. Many states in the Western United States. Yeah, we'll give it another minute or so as people continue to join. Welcome to you all. Oh, fantastic to see some folks associated with the WWAMI program, near and dear to my heart as I sit here at Harborview, University of Washington. And we'll give it about another minute. Okay, and so we again, we have our we had our disclosure information running in the background for your perusal. Let's get started. Thank you all for joining today's session of Providence, Alaska Project Echo Dementia. Let me go ahead and share my screen here. So if you're just joining, we're asking, please do put your name and your information in the chat in terms of where you are, your area of practice. We have such a large group, which is a really wonderful thing, but it precludes going around and doing introductions. So this will be our way of either making new connections or solidifying existing connections, and just wonderful to see where you're all coming from. So this, we are midway through our series here, and today we have the great fortune of having Dr. Jordan Lewis, who will be talking about non-pharmacological treatments and the role of culture in care. So I'm going to turn it over to him shortly. I will remind you that we are a multi-site, multi-organization effort here and cover a fair amount of territory. We have our hub team members here, the 6 of us, and in partnership with the Alzheimer's Resource of Alaska and Mountain Pacific Quality Health. Really lovely to have those connections as well. So we do have CME credit, and there are no disclosures for any of our planners or our speaker today. There's that piece of information. There's the way to claim CME credit. So you'd go through the Swedish portal and that code there in red, which will be in the handouts as well. There is that for you. We're going to move to the didactic content here in a second, but I wanted to thank Mary again for putting together this slide of where and who you all are. This is the where you all are in terms of people who are registered for this, knowing that not everyone joins every time. And then this is who you all are, and what a fantastic group of diverse providers with a tremendous amount of expertise. And really just, again, very, very grateful to be able to engage in this with you all. So thank you for your participation and your interest in doing what we can to take better care of our people living with dementia and their families and their communities. So thank you so much for choosing to spend your time doing this, knowing that there are so many things you could be doing. Okay. Our agenda for today will be to turn it over shortly to Dr. Lewis to talk about behavioral and psychological symptoms and non-pharmacological treatment. Dr. Lewis has also agreed to weave a case kind of through this for illustration purposes and to really drive this home. And then we'll shift to our closing notes, and we'll be sending out an evaluation shortly after this session. So keep an eye out for that. And we really do value the input to try to iterate this and make it the best program possible. So with that, I am going to turn it over to Dr. Lewis. I'll stop sharing my screen here if I can get rid of a couple windows. All right. And
all right, thank you.
My pleasure.
Let's see if I can make this work. Can everyone see that all right?
Perfect.
Skip all this. We just went over that. All right, thank you, everyone. It's wonderful to see some familiar names on this list and some people I've worked with for years. Do a quick introduction. I'm Jordan Lewis. My family are Aleut from Southwest Alaska, the native village in Naknek in the Bristol Bay region. We are the rival to Dillingham, anyone familiar with that region. Grew up there, commercial fishing. I'm a community psychologist and social worker by training. And prior to here, I was with the WWAMI program at UAA. So it's wonderful to see Dr. Young there and a few other names. I'm currently now the Associate Director of the Memory Keepers Medical Discovery Team, which is a new center established by the state of Minnesota looking at Indigenous dementia. And we're housed within the University of Minnesota Medical School in the Duluth campus. So I want to start off with why I'm not an MD. I'm a psychologist and a social worker. So this is a very heavy in the social sciences. And a lot of the experiences and stuff I'll be sharing is more of a culmination of the stories and experiences of our elders and the people we care for have shared over the years, the hard work of people who've worked with our older adults. And so I'm honored to have this opportunity to share what we've learned over the years. And so to kick it off, I'll just give some quick background. Approximately 90% of people with dementia will experience a behavioral or psychological symptom of dementia, or BPSD. We do know medications are effective for some aspects, but not always 100% effective unless there's other components involved. When you're looking at non-pharmacological interventions or working with BPSD, we need staff that have skills in using these. And how do you find the time to train, the resources to train them, and make sure they're up on how to do it appropriately and safely. We also know from our work that many Alaskan Native people with dementia or without are not always comfortable taking medications, nor do they have access, especially when it comes to dementia-related medications. And so with that, we need to start thinking about what are some ways we can treat some of these or manage some of these behaviors that don't require medication, that don't require extensive training, and can allow someone to age in place as long as they're able to, whether that's in their home or with their family. So what are behavioral and psychological symptoms of dementia? These are some of the most reported types reported by carers in the literature. So on the left side here, you'll see behavioral. Activity disturbances, for example, agitation, wandering, inappropriate activities, not having any initiative, Can also include aggression, and that comes in different forms. May also be seen as appetite or eating disorders, sundowning, where you see increased confusion or restlessness in the late afternoon to evening, and may include socially inappropriate behaviors. On the right side are examples of psychological symptoms. This could be affective disturbances, agitation, depression, anxiety. They may have a lack of interest or a lack of emotion, so they may be apathetic. They may have delusions or misidentification syndromes. People are hiding or stealing things, begin having paranoia, being suspicious about people, maybe talking about relatives who've passed on, other people who are alive that they haven't seen in a while or just saw, and hallucinations. And those come in the different forms like visual, auditory, the sense, the smell. So what are some non-pharmacological interventions? I'm sure we've all heard of a lot of different things being used, whether with people with dementia or in general. They are defined as any intervention intended to improve health or well-being that does not involve the use of any drugs or medicine. And they're primarily used to assist people with dementia to live as comfortable as possible as the world around them is changing, and allowing them to live as comfortable in a place where they would like to live and age. These interventions can also be used to treat pain, reduce stress, encourage positive changes in mood of an individual, reduce feelings of depression, as well as increase their awareness of self and the environment. They're also commonly used to redirect the person with dementia in a more safe way to reduce the escalation of, let's say, agitation or wandering. And we know in the literature to date that there's very little research on the benefits of these interventions, specifically for people with dementia, but this research is growing. And growing up and working with Alaska Natives and American Indians and other indigenous populations, anecdotally, we know this kind of stuff works. And the research is starting to catch up. NIH has the Center for Alternative and Complementary Medicine, looking at specific things like this, like aromatherapy, other aspects of therapies that are non-pharmacological. And so it's great to hear that research is catching up and showing us that there are actual physical and psychological benefits. So just some examples. This is not an exhaustive list of what's out there, but in terms of what has a strong evidence base, meaning who has done some research on this and has been able to prove there's a positive impact or a positive effect on a person's emotional, physical well-being. Music therapy is the most common form. I don't know if anyone's seen that documentary Alive Inside about the individual who brings iPods to people in their care facilities and creates customized music lists. But it's a phenomenal thing. Music is one of the last aspects of our memories to go. And so memory does hold a really important place in our lives as the disease progresses. Other strong evidence-based treatments include relaxation techniques. This could be mindfulness, aromatherapy, meditation, massage, or touch. We do know in some Alaska Native cultures, touch may not be appropriate in certain situations. So before you do these kind of techniques, make sure you have permission, you talk to the individual or their family to see what's appropriate or not. Animal-assisted therapy, whether that's real animals or robotic pets. We're seeing more and more facilities getting robotic pets put in. Also, the use of baby dolls or dolls have had an impact. Also, creative activities, whether it's art or it's poetry, and having the outlets. I just heard a story from someone this morning where someone in hospice had never been artistic in her entire life, was given pen and paper and started drawing, and a year later, hadn't passed away yet, but had her first art show. And she said, I never thought I was artistic until I had the opportunity to try it. And so it's never too late to try new things. Support groups. The other big one is environmental modifications, figuring out what's triggering them, what might be causing them agitation. Humor is another one, humor therapy. That's a real thing. There's an International Institute of Humor Studies that comes out with humor therapy guidelines and programs. physical activity, exercise is appropriate. Montessori techniques, this comes from the Montessori school for preschoolers. Same techniques are applied for people with dementia. So these are just a snapshot of what's available. There's many more. And this is no quick fix. We need to have training. We need to look at the behavior and try to figure out before we try applying certain techniques that the person we're working with, that we're living with, is trying to communicate that there's an unmet need or something's not right. And we need to help them figure that out. And so these may be some ways to help do that. So this comes from the work I've done over the years with the Fairbanks Denali Center, working with elders in my own family, and I've done successful aging research with my research team for 10 plus years. These are things that people talk about as we've either tried it at home, it works in our own family, but they don't have either no research has been done or there's very limited evidence. And so, for example, berry picking, is that something they're able to do? Gets them outdoors, if they're physically able to speak in their native language. Could be another way of managing some behaviors. Traditional food activities, whether that's eating the foods, helping them prepare the foods, reminiscing about the foods. This has led to us developing flashcards to use as reminiscence therapy with traditional foods on it. The Alzheimer's Resource of Alaska was wonderful in partnering with us on developing those, and we're in the process trying to figure out how to pilot that. Native songs, surprisingly, like I had mentioned earlier, music stays with us for a long time. In the care facility in Fairbanks, there was an elderly woman in her 90s, spoke very little English, more advanced stages of dementia, and the youth dancers practice there when they're able to, and they were trying to sing a song that they had known, didn't know all the words because one of the original songs their elders knew, so they kind of fumbled a little bit, didn't really know the rest of the words, but the elder started singing. She remembered when she was little, she knew that song. And so through her engagement, the youth were able to learn a new song that their elders knew. Intergenerational activities was really important to elders, whether that's elders and youth together, what that environment looks like, family engagement, and then spirituality. And this could range from a variety of different forms, from very traditional spirituality to more formalized. I had a medical student look at the role of spirituality and religion in dementia caregivers' well-being. And so that's very important. So shifting gears, I'll try to weave in a case study, and if Gay has anything she would like to add about anything she'd like to share, that would be wonderful. But over the years, I've been honored to work with Dawn Thibodeau, who's an Alaska Native social worker at the Fairbanks Denali Center. I would say we've known each other since 1997. We've been colleagues first as social work student and then now professionally and now as friends. But he's spent the last 30 years really figuring out how do you integrate culture into care facility that includes people with dementia. And over the years, I've been really wanting him to publish this or either just write it down. As someone who works with older adults, there's always this fear that if we don't write it down, it's going to get forgotten. So he tells you orally, but then we're like, well, there are other care facilities across the state that are trying to learn what you've done. So how can we make this in a way that's shareable? And this is a free PDF that's available for anyone who's interested. And I'm not going to go through all of it, but in his experiences of working with elders who either come in for rehabilitation or come in to stay until they pass on, he started noticing that the Western forms of healthcare really didn't have any culture involved. And so he really wanted to figure out, how do you bring culture to them, make them realize they're valued, and then translate that to educate all healthcare providers on culture. So another case study, here we had talked about, there's an elderly gentleman I've known for a long time, was at the Denali Center. Prior to that, let's say he was about 85 years old, he had early onset dementia, lived independently and was moved into a small group home, doing all right. And over the course of 6 months, they started noticing he wasn't eating, losing a lot of weight, became more sedentary, didn't get out of his room much, had his favorite recliner, just sat in front of the TV and didn't eat much, didn't get around, didn't visit with anyone, didn't socialize. They were noticing there was increased isolation. And so when I was in Fairbanks, I would try to go visit this individual as much as I was able to, and started noticing these things like, well, you know, is there anything we can do? Like trying to be the social worker, like, okay, let's think about the situation. What's going on? Are the other residents reaching out? Are they trying to engage him? And so due to rapid decline, they started to realize, the family realized, well, we should probably move this individual. Opening at the Denali Center happened, and they moved this individual into the Denali Center. Through, I'd say, over 2 months, with the serving of traditional foods, the traditional music that was available, whether through the youth groups and the dance groups practicing there, having it on a radio to play, listening to his regional corporation meetings, participating in cultural activities, he started gaining weight. He started eating again. He started being healthier. And the quote on here is what he said. It reminds me of home, which I really like. So we weren't able to keep him at home, but through the ability to serve moose nose soup or moose soup or salmon or caribou, things he grew up with, to see him eat and light up about, you know, we'd ask questions about, when do you remember what it was like when you got your first moose? Or do you remember, how did your mom prepare this when you were younger? Stories would come out of him, share, he would start dancing with the music. And so that was really powerful to see. And that's the kind of thing I think that this work is trying to do, is how do we take non-pharmacological interventions and bring in that localized culture that's so meaningful to residents or persons with dementia in their own home, that brings back positive memories and reaffirms their identity and who they are. So other examples is that they set up times for elders to give storytelling, whether or not they're good at it, but telling stories from when they were younger, stories they want to share now. They subscribe to every local newspaper in the state. So whether you're from Dillingham or you're from Nome, they get those papers so you can keep up if you want to read about what's going on in your region or your home community. They also have spiritual support, whether that's traditional spirituality, more formalized religion. They can have a rabbi come in, the pastor come in. They have this thing called the passing on cultural protocol. And so through learning by trial and error, they had learned that you need to ask these questions up front before the disease progresses to the point where you need to either try to figure it out on your own or try to get family involved. So at intake, there are passing on protocols, there's religious preferences, there's questions about who should be called first, should something happen, because it's not always the family first. In some communities, you call the pastor in that or the rabbi in that community, then they call the family. They also have a leave of absence program, which I think is very unique. Every Alaskan elder resident at the Denali Center who wants to go home, regardless of disease, regardless of medical treatments required or staff that's required, they can go home for up to 2 weeks, once a year. And so that, one, enables elders to stay connected to their community, and dispels the myth that people who go to a care facility just kind of give up and die. But they show up in their community, they have supports, they may still be very active and vocal, and still want to stay connected to their community. Other examples, videos, whether this is documentaries about certain communities, potlatches, celebrations in Southeast, celebrations in Interior. They use that. They also subscribe to tribal nation specific or national or state newsletters, newspapers. Food is all donated. It's a very cost-effective program. All the food's donated by families or people in the community. And what's unique about this, regardless of disease status, when it's safe to do so, all the residents are able to help prepare the food. And they get, if they're asked, they can use their own recipe. So Don may say, how's your favorite way to prepare this soup? Let's say caribou soup or salmon soup. And they share that recipe, and that's how they cook it. And then when they serve it to everybody, and anyone's invited, that elder can share what the recipe means to them and where it came from. And they can all share who donated the food. In the Denali Center, anyone can go to any community activity. They have a bus that takes them to powwows, to gatherings, Festival of Native Arts, to church, different celebrations. So they're visibly seen in the community. And that means a lot to these elders as well. So when of course, being the researcher, being an academic, particularly interested in, we saw the visible impact this had on the individual who was 85, who moved to the Denali Center and started eating again, started being more engaged and was no longer isolated. But through observations of the staff, we asked them, on days traditional foods are served, or on days Native groups come in and dance, or on days they seem more engaged with family or other people, let's ask them how things are going. And so these residents say, these cultural activities, like after eating good fish head soup, improves their quality of life. They feel better, they're happier. They say that it helps them maintain connection to their cultural values, their beliefs, their language, their traditional foods. These things were so important to them that when they first moved there, were afraid that wouldn't be allowed anymore. These all contribute to their sense of identity. In some cases, they feel that they improve the communication with their family, but also the staff. The staff starts spending more time getting to know these residents. Oh, their favorite food is this, or they're actually from Galena and their family are here, and makes it more personable. We also notice for elders or residents who are able to get around, they're more physically active, and they're most socially engaged, whether that's with their neighbors, with staff, with people there. So again, lack of evidence base. We haven't been actually to demonstrate this through research, but hearing about it from the residents themselves is meaningful enough for us. So recommendations, as a researcher, and my research team hears this all the time, is that, yeah, we have the PhDs, we may be the experts based on literature and research, but the recommendations should really come from those who are going to benefit from these things. So all these recommendations come from most of them come from the residents. Few of them came from staff who've been there for a long time and kind of see what works, what doesn't work. But training and educating providers on, you need to know the history of your elders. Where are they coming from? The situation where one elder, older woman, early stages of dementia, very isolated, was nonverbal, sat in her room a lot. All the nurses would try to come in and help change her garments, try to touch her and make her move. I'd help her move around, but they didn't know the history. They didn't know that she'd been abused by men or women in her boarding school days. And so being back, taken out of her own home, put in an unfamiliar environment, brought back a lot of those memories. And so that touching reminded her of the abuse, and that's why she kept withdrawing in. Wasn't until the social worker sat with her and just sat for 3 weeks and just sat and let it just be silence, that she started building up this trust, and she realized that people are there to help her. So know where your elders are coming from, what their history may be, good or bad. Also their family and their communities. Not every family is a safe community, a safe family, I mean. So before you engage families in treatment or have them come in, figure out if that's a safe alternative at the moment. Also, generational differences. This is an area that I'm still learning about, but we're starting to realize that some people in their 50s and 60s have very different lived experiences than some in their 80s and 90s, and being aware of that as you plan activities, as you interact with them. The elders said, if you could just learn how to say hello or how are you doing in my native language, means the world to them. So really basic phrases just to get to know that you're trying, you want to know who they are and where they're from. Offer culture-specific activities. And this comes out of the idea that they're not unhappy with the activities. We are noticing it's having an impact on their quality of life, but there may be others they want to do, like beading or basket weaving or something else that hasn't happened yet. More incorporation of elders' favorite recipes, which they're doing now, but they'd like to see more. Incorporating traditional dance and music. These last few recommendations are more for, let's say you want to start a new care facility in a different part of the state or a different part of Indian country. These are things they would say, oh, you should try doing this because it works really well here. Providing opportunities for arts and crafts, as well as for elders and youth to gather. The Denali Center does have a preschool there. The elders love to go and watch the kids. but what that looks like for older kids and elders to get together. That not only helps elders stay actively engaged, but reduces ageism among young people, helps them be more comfortable on older adults, and hopefully steers them towards a career working with elders. And let me check my chat. Gay, do you have anything you'd like to add?
Well, yeah, this has been wonderful, Jordan. Thanks so much. I do have this case that I've been working on. Actually, there's lots of different ones. What you're talking about reminded me of, but I could maybe give a brief overview of a case that the folks in the Valdez long-term care facility are dealing with, and they do not have the advantages that you've mentioned the Denali Center has. It's a hospital. It's a long-term care unit that is connected with the hospital. So they have all these regulations. They would not be able to offer native foods that were brought in by somebody else. At least I doubt that they would, because of the health issues and things like that. One of the other issues that they had a native woman come in, native elder, in her late 80s. She was from a village. And they hadn't really been given much information about the family, at least not initially. It did happen over the weeks that she was there, over the couple of weeks or so, they started getting more information, and it was very helpful for them. But initially they didn't have it. The other issue they had is their staff is completely burned out. They only have 2 staff people that have been trained at all in working with dementia people, folks with dementia. And so they had these new staff people, CNAs and stuff, who were trying their best, but would get freaked out when this woman was acting out or was agitated or, not able to understand what they were talking about. My initial contact was through the head person for the unit, and she talked about how they really needed training, and they didn't, that she was real unstable. She was a fall risk, so they couldn't leave her alone. She was very agitated and resistive to care and all these great things. She was in a totally new environment and suddenly plopped, just like you said. And they had no real knowledge of her background at all. Just like you said, it was really important that you have those informations. So she was eating okay. She didn't seem to have a trouble with that. But they did bring some belongings with her, that familiar things in her room, but I don't know that the staff ever tried to use them. I talked with our staff about it at ARA, and we came up with the fact that she's probably in the amber stage, just from the description that they were giving. So heading into the late stages. No verbal communication. She did have English words, but it was word salad. And so this was someone, and whenever they would try to help her with the showering, which she apparently had diarrhea initially anyway, and they needed to do it pretty often. And so she was fighting them. I mean, it seemed like she was fighting them. That was their interpretation of it. She would strike out and those sorts of things. One of the things our staff recommended is they do that thing of sitting and watching and seeing when did things start to go south? When did they have, what were their strengths? What she's still able to do. By the time I was called in to do a consultation with the staff, but again, they limit the times that I can come in to their staff meetings, and about 5 minutes, 10 minutes, maybe 15 minutes. And this is at the end of a fairly long staff meeting where everybody's in these little boxes and not showing themselves at all. So, they're not happy with this way of dealing with things. And they've gone through this long list of, you need to do all these requirements, all these forms they have to fill out, all these things they're supposed to do for the hospital and things like that. And so by the time I come on, it's like, I don't think they were listening at all. Why would they? So it's kind of like, okay, something else needs to happen here. It was better in that consultation. I was able to get a couple of people to share that initially they were talking about her being, one woman said she was combative, but then another woman came on and said, no, she's not combative. She's just confused and scared and those sorts of things. And so she's just irritated. She's not mean. She's happy. She's laughing when we're trying to work with her, but she's just striking out. It's like, how do you deal with that? And how do you interpret that? And that was one of the main issues. They were having a hard time interpreting it. So then I was able to visit finally at the end of the month. This was last month. I was able to visit, and I sat and watched for a while, and she was sitting at a table with a staff person that seemed to be quite fine. Then towards the end of my visit, I was able to actually sit with her, and she was with another staff person, a couple other staff person in the room. She had a doll, and she was spending a good deal of time with this fidget blanket. They'd given her one of those, and she was doing all kinds of things with it, trying to figure it out and stuff, and doing a fairly good job. She would look up and laugh and laugh. Mostly her communication was laughter. And she'd say some words, but it was all word salad. And so you kind of go along with it. And that's interesting. Well, thank you. We'd laugh with her. She seemed happy with that. After about 30, 40 minutes, it was like getting close to 3 o'clock. And that's when they said that's when things start to break down. She lashed out. It wasn't like she was lashing out at me, but she just sort of lashed out. Movements are really kind of like startling, and she would start to lean over and get for something. And so this whole issue of safety issues, and how do you interpret lashing out? If it gets interpreted as somebody who's combative, then we treat it differently. They did say that they had stopped using Seroquel, and that seemed to help her, at least during the first part of the day. And then she also looked at me and said, after having this lovely conversation, quote unquote, and spending this time together, she looked up at me and said, "I don't like you." It was like, okay. And again, how do you interpret that? If you're a new person, you don't understand dementia, it can be kind of startling. So those are some of the issues that this staff is dealing with. The staff that is the two folks that I know that have been there for a long time said they don't have time to train their new staff. They don't have enough staff. They're working 10, 12 hours shifts, and they don't have relief. And then they get asked to do all these extra things that don't have anything to do with the care. And so they're pretty discouraged. Now, as far as the kind of care they were giving her, it looked like it was pretty good, but they don't have time to do some of these other things that you've talked about, Jordan. Certainly and that's what I'm trying to get together with the head person and trying to say, okay, you're going to have to give me more than 5 minutes, or us, whoever it is. You're going to have to give us a block of time. And they have new CNAs that are just being trained. And I was able to spend about 45 minutes with them that time I was visiting. I just happened to be there when they were there. But again, it's more than one time. This kind of training is more than one time. You can't do it just once and expect it to happen. I've heard that from other facilities where they say, well, we've already had that training. We don't need it anymore. And that was last year. So I think some of these issues are above and beyond. Of course, this is about facilities, but it's the same kind of thing for families. Apparently what this family had tried to do is keep their mom at home for as long as they possibly could. And what they were doing to keep her from falling and getting hurt. And when she got too agitated, they were putting her in a chair and tying her in, and sitting her in front of TV with a movie. And that's what I was told. Now, whether that's the reality, because I haven't talked to the family. It sounds like the family is becoming more involved. There's one person anyway from the family that's becoming more involved. But it's that same sort of thing. One of the family members that the head person talked to on the phone said, well, that's your problem, not ours. That's why we sent her to you. Because she was asking for ideas of how they helped this woman. And he said, not my problem, it's your problem. So anyway, that's just a brief overview of one case, but my guess is it's all over the place. I don't know what people's recommendations might be for how to help a staff. Your ideas are great. I And I think that they would love to have those, but and as things are opening up now, it's probably going to become more of an opportunity. But I'll tell you, staff and families are to hear and really need our loving attention. And that's, and whether it's native or not native, that's another piece that I'm seeing is that this idea of culture. Yes, here in this right now in this particular facility, there's only one native person. It's a small unit. There's only one native person, and the tribe is different there. It's in Valdez, and so the tribe in Valdez is different from where this woman came from. So great challenges, lots of wonderful opportunities.
I'm curious too. I might be misreading this in the chat, but it sounds like there may be some other facilities or places that have successfully implemented these. And I'm wondering what they're doing right and how you do more of that.
I know of one place in Soldotna area that sounds like it's like the Denali Center, but that's the only one I'm aware of. Mm-hmm. There may be individual homes that are doing better in Anchorage, the individual smaller ones. I don't know that any of the bigger ones are doing this sort of thing. They may be, but I think the bigger facilities are being run by corporations that come from the lower 48 and have really no interest. That seems like that's one of the issues that was happening in at least one of the facilities that I know. They're big corporations that have taken over assisted living and making it a business rather than a service. And they have very little support for their family. I'm not saying all of them, but I know of at least one in our area, that in the Anchorage area. Now, I'm living out here in Kenny Lake in the Copper Basin, so it's really rural. It's not bush, but it's rural. The different individual Native communities out here have very little understanding of dementia. We've done a little bit of training, but they have not really picked up on it. And you can't force it. But it's more like they're focused on other things. I've heard that there's an increasing need, and the senior programs, the elder programs have been defunded in some of these areas. So it's, as I say, it's a wonderful challenge. And it's great to have all of you involved in this, because I think we're heading in the right direction, no question about it. And Jordan, your information is really valuable, and that's the kind of thing that these places need to hear, and encouragement to do more of that. And maybe even a sharing of culture. I'm sorry, go ahead.
Ursula, I see you have your hand up. Yeah, please.
Well, I was going to add, I think, to echo what Gay is describing is also more commonly my experience in working in palliative care, where we have very few skilled nursing facilities and most elders are cared for in assisted living facilities. And those might have 4 beds, they might have 50 beds. And some, like we cared for a patient where the staff said they had no dementia training at their assisted living facility and felt really ill-equipped. One of the things that kind of struck me about Jordan's presentation, and then also I was listening to a Jerry Powell podcast this weekend about kind of looking at regional differences in skilled nursing facilities, and a study that came out of how end-of-life care differences might be attributed to some of the behaviors or perceptions of different skilled nursing facilities. But they both spoke to, well, 2 things. One is this: the regulations are very little about understanding people as people, and for how regulated they are, and have very little leeway around tailoring what you're providing in a skilled nursing facility under the current regulations, for the person as an individual. We like to say in palliative care, it's this framework of so much of medicine is like, what's the matter with you? And then we really need to be saying what matters to you and focusing on that. And so whether it's the regulation, it's the culture, it's the environment of staffing where the payment model really doesn't support really operating these facilities the way they should operate is probably kind of underlying all of that. But then like, well, what can we do? What can we control? And I was thinking for like some of these facilities may not have a lot of Alaska Natives, or might have one and then not have another one if they just have 4, but everyone has things that matter to them. In palliative care and at Providence, we started doing this get to know me poster, and especially with being families less at the bedside, it's been helpful. But it made me think that on admission to a skilled nursing facility, that someone with dementia, to have their family filling out a get to know me poster, like how do I like to be, what's the name I like to be called, what are the things that matter to me, putting up photos of things. It's just one little tool to encourage a skilled facility or an assisted living facility to have as part of their intake packet. Because I think so much of that intake is what's the matter with somebody, but not as much about what matters to somebody. And maybe that would be one tool we use in palliative care that would be relevant for the things, all the things like Jordan described, just to how do you proceduralize that everywhere, an ALF with 4 beds, an ALF with 50 beds, a skilled nursing facility to have in their intake, a framework where they're finding out what matters to somebody as a person and how they want to be cared for, and how they want to spend their time for living in a facility.
Yes.
Thank you both for those presentations. It's like the aspirational side of it, and then hearing Gay, it's like that's a little more what I kind of find myself also trying to help with.
Right, and we'll go, I see that there's hands up and things, but just to tap into yours, the folks, the workers at the center that I've been working with now for 15 years, want to do it right. But their hands are tied in so many ways. And there's no way that the families could, or the persons can help with making things, unless it's, one little thing. They might be able to do an activity that's about one little thing, which is better than nothing, but still. Anyway, yeah, hands being tied.
Yeah, absolutely. And, really so important to have this kind of awareness of here's where the reality is and here's where we are. Here are the aspirational goals. Here are maybe some small things that can help us get there that don't presuppose what's important to someone. So that's a wonderful idea from the palliative care world. Barbara Bigelow, I see you've got your hand up as well. What would you want to add?
Oh, sure. Can you hear me?
Yes.
Okay, so just a couple thoughts, and I will try and be brief because I love the comments. First of all, Jordan, I wanted to say to you, when you talked about the elder who maybe had been abused in a boarding school. So nursing facilities today need to incorporate trauma-informed care into their work. And trauma-informed care compels us to figure out what types of adverse events in a person's lives come to bear as they enter nursing facilities, and what do we need to be aware of and sensitive to, and how especially might it impact the ADRD population, who's going to manifest it differently than maybe they did when they were a more cognitive adult. The second thing I want to say is any nursing facility in Alaska can incorporate indigenous foods into their programs. It is very, very simple. You have to have a written policy, and you have to follow the ADEC program for subsistence foods. And they publish what is allowable and what is absolutely forbidden in institutions. So nursing facilities are incorporated into those regulations as well as schools. So any nursing facility can do this. And Jordan, I saw Don Thibodeau do a presentation about 6 or 7 years ago. And Denali Center has a model program, and you're honored to be associated with him because it's really strong work. The other thing I want to say very briefly, first of all, We tend to look at co-located nursing homes with hospitals as units of a hospital. Nothing could be further from the truth. We are licensed CMS providers and we must follow CMS regulations. I encourage people to think about that when they're dealing with a co-located nursing home. And the last thing I want to say is we are absolutely forbidden to tie residents in chairs. And if there's a family perception that that happened, then there's a problem because that's a restraint. In almost everything is a restraint in today's world, and progressive leaders are very, very responsive to that. So, but specifically, I wanted to talk about the subsistence foods. I've done it in 2 nursing homes, and then we really have some model nursing homes. YKHC in Bethel is a model nursing home, and I think the Cost of View program has something very, very similar. So Jordan, your presentation today is fabulous, and thank you so much for your expertise and your advocacy for all of us and the Indigenous peoples. I appreciate it.
Thank you.
Okay.
It sounds like I need to make a clarification. The tying in was done by the family, not by the facility.
Yeah,
I know that.
Yeah, that's what I'm saying. Thanks.
Okay.
Well, and thank you, Barbara. I noticed in the chat too that you said you'd be happy to answer any questions and be a resource for anyone who would want more. Thank you for that.
Absolutely.
Yep, great. Other questions, examples of either, maybe not a facility, but a place or a provider or a family member, a community member who has done this well and it turned out well? Or other questions?
Could I say something?
Please do.
Okay, thanks. First, I want to give a shout out to Barbara. I haven't seen her in years, and it's great to see her. And she has lived experience and professional experience. So I'm so glad she's on this ECHO. I worked for 22 years at the long-term care in Kodiak, and I just remember how much our family council helped us. And we had around 50% Native and 50 mixed of other nationalities and ethnicities. But the families that, could feel empowered through a family council were very involved. And it wasn't always. Sometimes it'd be a whole year of just struggling to get that family council to meet, to have everyone, agree on a time and day. But when you do get one that's working, it's really helpful. They know their loved one and they know their culture. And we learn from them just being in the facility and encourage them to come for dinners and just teach us, about their loved one. So I just want to add that. I think the trauma-informed training is an excellent idea. And we certainly could have speakers, like speakers from the Native community that aren't usually on the speaker, platform there, but they know so much about their culture that they could and how the trauma happened growing up. They could help a lot. Also, on the previous speaker, we have at intake, we have the Who Am I form, and I think we got it from the Alzheimer's agency. And that helps a lot. The activity director or coordinator is crucial for picking up what activities can help a person from another culture, and how to just bring in, like if we had a person that was a fisherman, then she would use netting and all the tools that you use as a fisherman to just help him reminisce on that time. Yeah, and then of course we had our elders come in and show how to make pirog, and yeah, so just brainstorming. You know, I do think we're at a different time after COVID to kind of restart all this, because COVID just shut down visitors so bad. I had several loved ones at the elder house, but they were always locked down because of suddenly one person got positive, same as the ALF. I'm a care coordinator now, and I have a lot of clients there, but was locked down. So yeah, but it's a new beginning. So I think maybe this will all come together and work again. And anyway, thanks for letting me make my comments.
Oh, absolutely. And it's so important, the family council idea is a great one. And, I think sometimes we are looking for the top down, legislative or other guidance or funding or, and it really has to be grassroots or, everyone rowing in the right direction, in the same direction. So yeah, great point. We have a couple more minutes here. Other comments or thoughts, questions, experiences?
Well, I'll make a comment again. We have been moving, and COVID did rearrange the landscape for a couple of years, but very much the industry of serving folks in the continuum of care, whether it's assisted living, home and community-based services, and nursing homes. We are moving towards what's called person-directed care and person-centered care. So our residents who are in facilities need to be the center of our attention. We need to do everything in our power to meet their needs on a level playing field with them, so that they have quality of life as they finish aging in place. So person-directed and person-centered. Thanks.
I think that's a wonderful comment, and it was making me think of one of the things that we like to focus on here are retained strengths and resilience, and the things that don't change. Particularly in the early mid stages, but even into sometimes some of the later stages of dementia, and just really helping people and families lean into the disease by tapping those. And that really, it takes time, it takes work, it takes protocols, and kind of, again, everyone buying in that this is the right and the important thing to do. But boy, what a lovely overview today of how that can work and how it has worked in some places.
Mm-hmm.
So I'm with the Center for Human Development, and years ago we did a research project. This was before my mom was diagnosed with dementia, so it's so relevant for me now, on developing these PowerPoints that were for patients with dementia living in an assisted living home. And it really did go through all of the things that Jordan was talking about. It talked about who's your family, and my name is, and it was like, my name is so-and-so. I have 3 children. I grew up here. Here were my parents. And so that and then it would give little hints on what you could do as a care provider. Ask them about their children. And if you knew their names, their children's names, it might elicit a response. I think that the criticism that we received, well, there were 2 things. One was that at that time, people didn't have access in assisted living homes to computers. So having the staff watch these PowerPoints, I'm hoping that's changed, was difficult. We also noted that a lot of staff that were working in the home that we were piloting this in were English was a second language. So I think honestly, it was a better format for them. than just having a really text heavy kind of care provider, or, you know, like a written description of that person. But the other criticism, though, that we received was we had very specific kind of, these are my care needs. And I'll be honest, you know, I didn't realize how quickly dementia could change, you know, and you could progress through those. And so maybe I helped create this PowerPoint for one patient, and at that time they're independently taking their medication, but by the time it gets to the staff, they're no longer capable of doing that. So that is one thing that we really learned. I have to say, having seen now with my mom, and we are still caring for her at home. And so we are at the point of now needing 24-hour care providers. And that's a whole nother journey. And I'm thinking I need to create one for her so that all of these care providers that are coming in will have a quick rate of like who she is and what's important. So the thing that I think, Ursula, I think it was you that said what matters. And that's what this was about. Just wanted to share that.
Well, thank you, Karen, and thank you for being so forthcoming about your personal connection to the disease, which many of us have. And boy, it's hard sometimes. And Jordan, I wanted to thank you for making the point and reminding me that behaviors, these quote unquote problem behaviors, are typically an unskillful or the most skillful attempt to communicate an unmet need that the person is capable of at that time. And to really kind of reconceptualize that and go back to rethink what is it that might be driving this. So important. And you really need to know the person as much as possible to be able to do that. Gay, your case made me wonder, what were the duties of this person at 3 o'clock that, she might not be able to do, and, now, and how do you try to figure that out and meet those? This is hard work, but it's so important, and really appreciate all the discussion about it today. Any other things in our last minute or two?
I think that thing about the trauma, I really appreciated, Barbara, you're bringing that up, the trauma-informed care, because I think that's probably deeper than we think. I know there's been other cases where people were getting hallucinations, and that seemed to be, it was almost like, you could almost see it, but I didn't know the background. So, and how do you ask families, hey, was this person abused when they were a kid? An awkward question to ask, especially families that are feeling threatened anyway. Just some thoughts on the who am I questionnaire. I know we have one. We're actually looking at adjusting it to be more user friendly. It's another one of those documents that's pretty Caucasian, and so that's something to be thought about. And I think, as some people have mentioned, there's lots of different cultures out there, and we need to be thinking about those as well and finding ways to appreciate each other's cultures. Just thank you for letting me spout. Appreciate it.
Absolutely. All right. Well, we are almost at the appointed hour, and out of respect for your time and appreciation of your time and your involvement, this has been fantastic. Jordan, thank you so much for providing us a wonderful didactic and launch point for a great conversation. Next session in 2 weeks will be the other side of the coin, which are pharmacological therapies, which have their place and role. And that'll be Dr. Reza Gomi providing that. All right. Well, take good care of yourselves and each other. And as always, thank you so much for being involved. You will receive a survey if you haven't already, and we look forward to your input. See you in a few weeks.